And we always come across this kind of a scenario where we don't know what to do when a child just has fever without any localizing signs. What are we supposed to do? Now the definition of PO actually came in 1950s, and it was said that any fever that lasted more than 3 weeks, greater than 38.8 degrees Celsius, and even after 1 week of hospitalization when you were not clear about the diagnosis, it was labeled as PO. That has been modified now. Instead of hospitalization, it is 1 week of intensive evaluation, and you don't have a diagnosis, you call it as PO. There have been various studies that have been done across the world to find out what were the common causes of PO. And the most common causes is infection, followed by malignancy, then collagen vascular diseases, and in 7% you still won't have any diagnosis what the fever was. For purpose of management, it's not practical to not investigate the child for 3 weeks or not come to a conclusion. So for purpose of management, an FUO is diagnosed when you have fever persisting after 14 days of treatment. And what you need to exclude it is that the fever is there but it's coming down, then don't label this as PUO. You know this is periodic fever, then it's not PUO. And when you have recurrent episodes of fever, that's not PUO. So these are the three that you need to distinguish and not say that they are PUO. Now, there will be a little overlap from the talk that I had taken in the PIDC, the Pediatric Infectious Disease Conference that I do every year at Mumbai. So I had spoken on travel infections at that time, and a little bit Dr. Bala Subramaniam is going to feel that it's a repetition of that talk. But don't forget, whenever you deal with PUOs, don't ever forget to ask two histories, history of travel and history of animal exposure. That gives you a lot of diagnosis to a lot of PUOs, especially if it's infected. In your physical examination, don't forget to look for mouth ulcers. Don't forget to look for lymph nodes. Look at the joints and look for a rash. So these are the things that you must keep in mind in your history and examination whenever you deal with a child with fever. Now, routine tests that we usually do in a PO, we do a complete blood count, we do ESR, biochemistry, urine culture, chest X-ray, blood culture. And most of the times, we label them as PO when all this comes normal. Some additional tests that the Western books would recommend to you is to do a CT abdomen, CT sinuses to actually pick up sinusitis or some abscesses in the abdomen. But this would be based on clinical symptoms and clinical judgment that you take. There would be a lot of studies that actually said in the olden days, when there was not much of investigation, they used to say that pneumonia, sinusitis and otitis media were the commonest causes of PUOs. But now that we have more and more investigations available, it's been found that EBV virus, osteomyelitis, Bartonella and complicated UTI, these are the common causes of PO. So as the decades pass, the infections that are causing PO are going to change. Most of the times we get a PO with hepatosplenomegaly and we say it's a reticuloendothelial disease. And when we think about reticuloendothelial disease, we think about dengue, malaria, we think of typhoid. But don't forget Bartonella, don't forget Mycobacterium, that is both MTB and non-tuberculous mycobacteria. Don't forget non-typhoidal salmonella, that's an upcoming infection that we are seeing now. Brucella and of course tularemia. Among the inflammatory causes, a lot of times we miss Kawasaki's. We're going to have a lecture on Kawasaki's later. So don't forget to look for red lips, strawberry tongue, cervical lymph nodes in any child who's less than 5 years with persistent fever. This could be an onset of systemic onset JIA. This could be an HLH presentation. You could be having sarcoid, or it could just be an inflammatory bowel disease which could be coming to you as PUO. Vasculitis, Behçet's disease. That's why I said look at the mouth, look at the ulcers. Look for uveitis. Vaginal granulomatosis. Look at if there's any renal involvement with a respiratory problem, then you're picking up vaginas, and then you do an ANCA test and it comes positive. And obviously an occult malignancy that we are missing out, a leukemia and a lymphoma. Last but not the least, don't forget drug fever. A lot of times we have seen fevers being treated with multiple antibiotics, fever just not responding to ceftriaxone, you shift over to piperacillin tazobactam, fever is not responding. And then you find that when you stop the antibiotic, the fever disappears. That's drug fever. The child will be well in spite of having fever. There may be a rash, there may not be a rash. You may get eosinophilia, you may not get eosinophilia. Most important is the fever disappears within 48 hours of stopping the drug. So be very careful when you're just using antibiotics left, right and center for any fever. It could just be that your antibiotic itself is causing the fever. And always keep in mind that a child with fever who's looking well, this could just be drug fever. Remember, recurrent periodic and hereditary periodic fevers are not PUOs. So something like your hyper IgD or your FMF or FAFA, these are not FUOs. Let's go on to a case. Standard case, 9-year-old girl, she's had fever for 3 weeks. There's no rash, no complaints, no localizing signs. She's admitted at a local nursing home after 1 week of onset of fever. So she's been hospitalized now for the last 2 weeks. Her serial CBC showed thrombocytopenia and a leukopenia. She tested negative for dengue, malaria and enteric. Because she was clinically suspected to have enteric fever, she was started on ceftriaxone and ofloxacin, but the fever spikes continued, and so she was referred to Nanavati for further management. On admission, she had a fever of 103, she had pallor, she had hepatosplenomegaly, other systems were normal. And these are her serial CBCs. You can see that she has a total leukocyte count of 3,300, and it's initially to begin with, which is still low for the kind of fever that she gets, and she has thrombocytopenia. So what do you think is the cause of the fever? This is the standard thing that you keep. Yes, leukemia could be one possibility in this child. She's thrombocytopenic, she's having fever for almost 3 weeks now. You're not picking up anything on culture, your Vidal's negative, you're still treating for enteric fever. Malaria going on for 3 weeks. So this is where you go on to your history. Find out, I told you 2 things, travel history and exposure to animals. This child was from Andhra Pradesh. This child had gone back to his village in 2 months back, and there were cows in his house and he had played with the cows. So you get this history now. Now what do you think of something? Brucellosis. So now we think of brucella, you send a brucella IgM that's positive. And the treatment of brucellosis, we've had various antimicrobials being discussed. Doxycycline. So brucella is a gram-negative organism. It's an intracellular pathogen. Remember, whenever you're treating intracellular pathogens, your antibiotic choice is slightly different. And it's seen predominantly in cattle, goats, sheep. And in children, it will come to you as fever, it may come to you as osteomyelitis, it may come to you as granulomas, it may come to you as splenic abscesses or liver abscesses, microabscesses, and even meningitis. Diagnosis is by culture. Whenever you suspect brucellosis, you have to ask the lab to culture for 28 days and not only for 1 week. And ELISA is the other way of diagnosing it. Treatment is a combination therapy. You don't give isolated doxy. You give doxy plus streptomycin or doxy plus rifampicin. Children less than 8 years, you give cotrimoxazole and rifampicin. Treatment duration is usually 2 to 3 weeks. For meningitis, the treatment duration is much longer. So remember, travel and animal exposure. Let's go on to our next case. This is an 18-year-old boy. He's had fever with chills for 3 days. So he's not exactly fitting into your definition of FUO. He's had a diarrhea episode 1 week prior to the fever. He's had no response to antimalarials. His investigation show normal CBC, malaria test negative, a urine negative, normal, chest x-ray is normal. So a PID consult is asked for. What would you think in this child? You don't have a UTI, you don't have a pneumonia, you don't have malaria. And this child has fever with chills, there's no thrombocytopenia. You would think of typhoid, what else? Viral fever, what else? But why would the viral fever cause chills? UTI, but we've got a urine which is normal. Intra-abdominal infections. Travel to Bihar. Okay, so we're thinking of Kala Azar. Okay, so there is a history of travel. When you go back to the history, this child had traveled to Sri Lanka 20 days ago. He had eaten street food, done bungee jumping, snorkeling, traveled to wooded areas, visited the brackish waters in a boat but not swam in that, visited an elephant farm, fed the baby elephants, visited a turtle farm, touched the turtles. Now can you think of what is likely? So you've got salmonella, he's eaten street food. Anything from elephants, anything from turtles, anything by visiting the brackish waters. Brackish water is a source of Vibrio. Okay, so it's not necessary it's Vibrio cholera itself. There are lots of other types of Vibrio. So they may lead to you as diarrhea, but they don't usually lead to fever. Turtles are the ones that harbor non-typhoidal salmonella. And so a lot of Chinese places that you go to eat food, and if you feel that you want to touch the turtle, then be a little careful because you'll end up with non-typhoidal salmonella. So here the suspicion is actually street food and the turtles. So your thing that you would consider, so this is the turtle farm, you can see how the turtles can be touched. Yeah, so you think of salmonella and non-typhoidal salmonella. So you ask for a blood culture, and here actually this child had non-typhoidal salmonella, which was treated with oral ciprofloxacin, and he responded. So not necessary that every fever is typhoid. You could have non-typhoidal salmonella. We usually think of non-typhoidal salmonella in immunocompromised patients, especially children with MSMD, that is your mycobacterial Mendelian susceptibility to mycobacterial disease. But you could get this if you are in a setting where you've had a travel history or you touched animals. And always ask for history of pets in the house. You'd be surprised with what various kinds of pets that Indians keep and what kind of infections that we could get through them. Now this was one consult that I had done on the telephone. A 12-year-old boy had fever for 3 days, had hemoconcentration, thrombocytopenia, dengue NS1 was positive, IgG positive, was treated with IV fluids and ceftriaxone. Fever continued to persist. On day 7, this child had a fever of 106, and the CRP increased from negative to 48. Blood culture, Vidal, Optimal, Leptospira, all negative. So the consultant called me up and said, what do you think we should be doing? What would you have suggested? This is a proven dengue. He had hemoconcentration, thrombocytopenia, but the fever persisted. So we think of a secondary gram-negative sepsis. This child has already been on ceftriaxone. So obviously on the phone I said, send a culture. Let's send a blood culture again. And you cover him for an ESBL. So you change the antibiotic from ceftriaxone to piperacillin tazobactam. Let's wait for 48 hours. If the fever does not respond, then I'll come and have a look at the patient. So they repeated the blood culture and the complete blood count. They shifted the antibiotic to piperacillin tazobactam. 48 hours later, CBC shows leukocytosis, platelets are 150,000. Fever is still persisting. And now they asked me to come and have a look at this child. When I saw the child, he had a fever, there was no relative bradycardia, there was a strawberry tongue, systems were normal. I went back to the history, I said, any animal exposure? He said, we just bought rabbits at our house 1 month back. Can you think of something that you can get from rabbits? So a lot of fever. Now why I'm stressing on all these animal exposures, a lot of fevers is actually zoonosis. So a lot of your POs are actually zoonosis. So can you think of something that comes from rabbits, though never proven in India? Tularemia, yes. So you think of tularemia. Tularemia is actually going to cause ulceroglandular disease. So you should get glands, but it can cause typhoidal-like illness. So you could suspect tularemia in a child with exposure to rabbits and having typhoid-like illness. So this child, the treatment actually we started was doxy on a clinical suspicion of tularemia. Diagnosis is by an ELISA, which is not available in India. So we started the child on doxy and the fever came down in 48 hours. So a lot of times your POs are actually zoonosis. So keep that in mind. And in our country, we should still be thinking of infection, infection, infection. First 3. Fourth, inflammatory or autoimmune. And 5th would be malignancy. So fever in travel in individuals can be common. It can be from influenza to dengue to non-typhoidal salmonella to typhoid to anything. With exotic sports that we are doing, adventurous sports, traveling to the woods, you're going to land up with exotic infections. So travel history and animal history becomes important. Now a little bit on Weil Felix test. You said you see a lot of scrub typhus here. We hardly see any typhus in Mumbai, but we see a lot of positive Weil Felix. Whenever we send for a brucella, what the lab gives us is also a Weil Felix along with it. Now this child has been having fever for 20 days. 5-year-old. He's been treated with oral cefixime, chloroquine, amoxiclav, but no response. Hemogram, blood culture, Vidal, chest x-ray, ultrasound, abdomen normal. So a brucella is suspected and a Weil Felix test comes positive. OX19, OX2 in the titers of 1:80. This child has no rash, no eschar. Would you give this child treatment for Rickettsia? How would you interpret this Weil Felix? Now, Rickettsia in India are of two types, scrub typhus and the Indian tick typhus. Scrub typhus is caused by Sutsugamishi and Indian tick typhus is caused by Rickettsia conuri. Among the Weil Felix, if we are to take, scrub typhus is going to have OXK positive. There will be an eschar at the mite site, mite bite, and you will have lymph nodes, obviously a rash and hepatosplenomegaly, but look at the eschar and the lymph nodes. And OXK positive. Indian tick typhus could have a rash which is more purpuric. This was the only child I have seen with Indian tick typhus. The rash is rare, lymphadenopathy is absent, and they have OX2 and OX19 positive. Now this child, if you go back, he had OX19 and OX2 positive in 1:18. So this goes towards Indian tick typhus, but this child doesn't have a rash. Now what titer do you take positive? Usually titer of 1:320 is taken as positive, or you need to document a 4-fold rise. So 1:80 titer didn't make sense. A child having a Weil Felix positive without a rash didn't make sense. So this probably was a false positive Weil Felix, and a lot of times we see this in Mumbai, false positive Weil Felix. I don't know what the experience here in Hubli and Dharwad is, but probably you'll have to interpret your Weil Felix with caution when you're treating. Further details, there is no joint pains, no rash, no contact with tuberculosis, no contact with animals, no drinking unpasteurized milk, there is no recent travel. What you find is only insignificant cervical lymph nodes. You do a count, you see hemoglobin is okay, WBC count slightly high, platelets are high, ESR of 67, Brucella negative, RA factor negative, but you have an ANA positive. So what's your diagnosis here? A lot of times you will be called for a consult like this. You have thrombocytosis here, you have an elevated ESR here. Yeah, so you're thinking of systemic onset JIA here. This child was treated with naproxen, to which his fever subsided, and subsequently he was put on steroids and methotrexate. So not all fever is necessarily infective, and you don't need to actually give so many antibiotics. Your CTCs give you a lot of idea. If you have thrombocytosis in a child with fever, the bell should ring that probably you're dealing with an inflammatory disease and not infection. You could have sometimes recurrent fever. This is not exactly PUO. We said recurrent fever is not PUO. But you have a 10-month-old girl who's referred for recurrent fever for 6 months. You find everything normal, X-ray normal, HIV, MAN2 negative. What do you keep in mind? I don't think I need to tell pediatricians this. But any recurrent fever in an infant, you keep in mind UTI. So you don't forget a UTI in any patient with PUOs. This would be one of the things. A lot of times you have PUOs in a diagnosed case, like say a child with leukemia on chemotherapy or a child with aplastic anemia. He lands up with febrile neutropenia. So we have a diagnosis there. This is febrile neutropenia. But we don't know what the cause of the febrile neutropenia is. Now this child is 12-year-old girl. She's diagnosed as aplastic anemia. She's on steroids and cyclosporin. She comes with a rash and fever for 5 days. On examination, the rash is basically a bleed. She's ecchymosis. There's fever, she's pallor. There's no organomegaly. There's no lymph pains, no lymphadenopathy. You say this is febrile neutropenia. On the basis of investigations which show pancytopenia and absolute neutrophil count of 100, you make a diagnosis of febrile neutropenia. Now, we've always been taught as residents, febrile neutropenia, send cultures from all sides. So send a urine culture, send a stool culture, send a blood culture, do an X-ray chest, find out the focus. All the cultures, urine, blood, stool cultures negative, X-ray chest normal. Febrile neutropenias are always started on antibiotics, so empirically this child was started on ceftriaxone, amikacin. The fever persisted in this child. We had no clue where the fever is, and there is fever still there. Subsequently, this child was changed to meropenem vancomycin. So obviously, a better coverage for both gram-positive, gram-negative was done, but the fever still persisted. Any fever more than a week in a febrile neutropenic child, think of fungal. Fluconazole was started. Fungal cultures were sent. All were negative. She continued to have fever. Now a PID consult is asked for. What are you going to do? This is common. You would be seeing this in your practice, that you would be seeing a febrile neutropenia where you tried everything, antifungals, antibiotics, nothing's working, none of your cultures are growing, and you don't know what is there. Now remember, whenever you have a neutropenic child, always think in mind of invasive fungal disease, and it's not necessarily invasive means a blood fungal positive. You could have an invasive aspergillosis. You could have a CT sinuses. So when would I do a CT sinus? In this kind of a setting, where I want to look for occult sinusitis. Here I asked for an HRCT in this child, and it showed a ground glass appearance with a nodule with a ground glass appearance around it. Can you think of what this could be? Is it TB? This could be aspergillosis. And how do you prove this is aspergillosis? Aspergillus can be a colonizer. So if you do a BAL and you get aspergillus, it's so much there in the environment that we could be having aspergillus as a colonizer. Yeah, so you need to do a lung biopsy actually to prove aspergillosis. The other way to do is look for galactomannan. You do a beta-galactomannan test, which can be positive. This test is a blood test. It could be positive, false positive, if you're given ceftriaxone or cephalosporin antibiotics. So you have to make sure that when you do this test, the child is not on cephalosporins. Otherwise, you could have a false positive test. And the treatment here is actually not fluconazole, but voriconazole. So this child was treated with voriconazole. He required it for a pretty long time, and the fever responded. So whenever you have febrile neutropenias, which could be one of the causes of your PUOs, you need to keep in mind invasive fungal diseases and investigate for the same. So I'm going to conclude here that whenever you deal with PUOs, keep in mind infections, autoimmune, malignancies. In neutropenic patients, don't forget sinusitis and fungal infections. You need to take a detailed history and clinical examination. Don't forget travel history. Don't forget animal exposure, unpasteurized milk. Use antibiotics with caution. Don't just keep on giving antibiotics because fever is not responding. Here is a time where you may need a PID consult early on in the disease, and you need to investigate as per the clinical suspicion. Thank you very much.